Hi, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Bright Spots Ventures. Our mission is simple: find what actually works in healthcare and help you all scale it. Each episode, I sit down with senior leaders from health plans, health systems, provider groups, and other innovators across the industry to cut through noise, share honest conversations, and unpack proven approaches delivering real results in the real world. This isn't a show for spectators or buzzwords. Really, it's for builders. It's for innovators. It's for the courageous, the ones not afraid to push progress inside their organization and beyond. If that's you, hit subscribe. You're home. This is your Bright Spots in Healthcare podcast. Greetings, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Glazer, and this show is produced by my team at Bright Spots Ventures. And our mission is to spotlight what is working in healthcare and help scale it. We bring leaders together across health plans, providers, and innovative solution organizations to share strategies that create real-world impact. If you've not yet subscribed to the podcast, I ask you the favor of taking a moment to search for Bright Spots in Healthcare wherever you listen to shows and hit subscribe. This way, you get access to incredible insights from all of your peers, and so do your fellow leaders. They could easily find the show more easily find the show if you subscribe. So appreciate that in advance. Today's discussion is about something deceptively simple but incredibly hard inside healthcare organizations. What actually happens when no one is watching? Care is largely designed around our visits. We got appointments and encounters and things on the calendar, right? But diseases, as we know, they don't kind of progress within those 15-minute increments. It evolves around days and weeks between those visits. And this is the challenge that you all face if you're listening right now, and it's not unique to healthcare. When you think about a personal trainer, I was part of this personal training program for a couple of years, and everyone knew like the 1 hour you spend with the trainer isn't what changes the health. It's what happens between those training sessions, the other 167 hours, and so the trainer could provide your guidance and accountability, but the transformation happens between those sessions. And healthcare, of course, works the same way. We design around the visits, but the chronic disease evolves in daily life between encounters with the system. And that creates a central challenge for health plans. We often measure whether care was delivered, not whether the risk was changed afterwards. So the real question isn't whether the visit occurred, it's whether you influenced what happened after the visit ended. So this shift from episodic to longitudinal presence is what today's conversation is going to be all about. And if that transformation happens in the 167 hours between the sessions, knowing that that's the challenge, I think healthcare has a design problem. We're organized around visits, and the outcomes are shaped somewhere else. So all of you who are going to win here, you're not going to just deliver care, you're going to influence what happens between the encounters. And that's what we're going to talk about. And that's why DarioHealth is supporting today's episode. If you haven't heard of them, Dario focuses on helping all of you at health plans extend care beyond the clinic and stay present in the moments that follow that treatment. Their approach combines data, adaptive personalization, and targeted human support to drive lasting behavioral change. And it's all powered by a lot of billions of points of real-world data that they collected from their years of direct-to-consumer experience. So if you want to learn more about them, you can check them out at DarioHealth.com. We appreciate their support. That is, by the way, DARIO health.com. All right, let's get started. Here we go. We have an incredible group of leaders that you see in front of you if you're watching on Zoom. And if you are listening on the podcast, I will introduce them to you. We're also going to provide their bios in the show description and in the Zoom chat so you can get a sense of their entire expertise and what you're going to benefit from. But in alphabetical order, from Healthfirst, Dr. Deborah Hammond. She's the Vice President and Medical Director there. We have from Highmark, Dr. Tim Law, Chief Medical Officer up in Pittsburgh at Highmark. And from Colorado Access, Jamie Zayas, Senior Director of Care Management. And last, but certainly not least, is Dr. Omar Manejwala. He's the Chief Medical Officer over at DarioHealth. All right, we're going to take all of these great leaders together. We're going to talk about, explore what it takes to operationalize continuous care inside all the health plan environment. Tim, I've known you the longest. I'm going to put you on the hot seat first.
Sounds good.
All right, most plans have invested heavily in remote monitoring and digital tools, but most discover that the data alone doesn't translate into better outcomes. Can you talk to us about how Highmark, what you are doing as a recognized lead, like you guys completely reinvented how you use digital tools. Can you provide us some insights to when you recognized a traditional model wasn't giving you enough visibility into member risk and what you built differently to intervene?
Yeah, thanks for that question, and thanks for having me today, and especially with this esteemed list of guests you have. So listen, back 3-4 years ago when prescription digital therapeutics first came out, Highmark, we were right at the beginning of the train trying to figure out how we can get these covered. And we did. I think we were one of the first options in the country to actually have a coverage there. But then we realized, listen, we don't lose our members, and patients and providers don't lose their patients at the visit. It's somewhere in between those visits. So grandma goes in to get her diabetes checked in January and the doctor says come back in June. What's grandma doing between January and June? No one knows till she gets back in June. We check some labs to see what her sugar's been averaging over the last 6 months or 3 months, however often it is. We said, well, we need to get in there in the middle because it's not about increasing the lifespan of people so much. It's about increasing their health span, keeping people healthy. And you can't do that episodically once or twice or 3 or even 4 times a year. We looked at the mental health space. We said, look at mental health. Like they're seeing their patients every week. But then we thought, well, there's still a week that they're not getting mental health treatment at that point. So we wanted to look at, say, how the different wearables and continuous signal detection, two-way escalating the story both ways. So you get from member to the plan to the provider. Early on in the process, pre-COVID, pre digital therapeutics, the fight was always who owns the data. If the health plan bought the wearable, then the health plan's like, I want the data. Well, if the provider doesn't get the data, it hasn't done a thing. And if the member bought the device, then like who gets the data first? Is it the provider? Is it the member? Is it the health plan? And so we had to come to an agreement, so to speak, in the industry to say, listen, everyone needs that data. You're not doing a darn thing for anyone if they're just looking at their blood pressure, their weight, and all these other things that tell us what's happening. If you're not sharing that information back and forth, so it's earlier innovation before escalation. So you've got a CHF patient, you're worried about did they gain weight, and you don't see them back for 3 months. They could be in the emergency room 2 or 3 times that amount of time. They're collecting fluid in their lungs, collecting fluid around their heart, et cetera. Well, if you have certain the devices that are out there now, we can see that before it happens. We can have a nurse or even a doctor call them and say, hey, what's going on? There's devices now. You can listen to their heart remotely. You can send them for a chest X-ray instead of having them go to the emergency room, things like that. So we're starting to design. I think the whole industry is, not just Highmark, designing population health around daily life, not around visit cadence. So we're trying to move from this episodic, reactive approach to medicine to a proactive approach, and with some longitudinal visibility there.
It's good stuff. So what you're describing is visibility. It's necessary, but obviously it's not sufficient. And thus you could be able to hopefully see risk earlier.
Yeah, because we do all that education while they're in the room with us. But then how much does that sink in until they get home? And so if we have a continuous feedback loop between us and the patient while they're at home, either with a 24/7 nurse line at the plan, or with the doctor's office themselves, or we can escalate to call the doctor and say, hey, doc, we think your patient might be having a problem. It looks like their pulse ox is down 4 points and their weight is up 5 pounds. And in this patient, that's a big thing. So then the doctor can say, hey, bring them in the office before they get 10, 15 pounds overweight with an oxygen that's 4, 5, 6, 10 points lower, and then they're in the emergency room.
Got it. So even when you see the risk earlier, you still have to get them to engage, and you leverage that doctor relationship to do that.
Exactly.
I'm going to go over to let's move over to Colorado. Jamie, your team has been rethinking engagement as well. And what has surprised you the most about, you see the data, you see the risk, now you got to engage. So what surprised you the most about what works and what doesn't?
Yeah, a few years ago, our team relied heavily on cold calling members with chronic conditions via our clinical registries. Over time, it became clear that that was not the most effective way to reach and engage our members. And we knew we had a large population of members with chronic conditions, and we had limited staff resources, but we also had growing demands and expectations around helping support condition management amongst our membership. And so we knew at that point in time, we needed a broader set of tools in our toolbox to engage these members. We also recognized at the same time, we have a lot of great programs in and around the Denver metro area that exist for members with diabetes. And one of the biggest barriers that our members face is actually getting to those programs. And so the friction point wasn't the clinical aspect of things, it was those social determinants of health. It's the transportation. It's the I don't have childcare to step away to go to this program. And so that really pushed us as an organization to explore digital remote options for our members. And we have had the pleasure of working with Dario. That's where we landed a few years ago, back in 2022. And we really appreciated it. Offered a menu because we wanted a variety of tools for the members to choose from. And so we wanted a tool that could offer, if somebody wanted a live coach, they could talk to somebody. There's an app that they could use on their phone at any time of day, right? Where maybe my staff isn't available, but at 2 a.m. you're bored and you want to hop on the app, you can do that. And we wanted to make sure that we had those connected devices. That was really important for us to be able to have members track their weight, their blood pressure, their blood glucose, so that they can then take it to the provider and share those results with their doctor. And it really gave our members that ability to choose how they wanted to participate, which was something new to us. We had never explored that before. And as we implemented it, we took a nuanced approach due to some limitations we had with the size of the population we could engage. And so we broke things down into different subgroups: diabetes and depression, members with diabetes, and high ED visits. And it was interesting because we assumed going into this that it was going to be our younger members who were more maybe tech savvy that were going to enroll and engage. And it surprised us when we started to get results back that it was actually the members who were 55 and older who seemed to be enrolling and engaging more than the younger folks. So that was something new that we learned. And things that went well. Whenever you're looking for a tool, make sure you're going into your demo process, knowing exactly what it is that you want, the must-haves in the tool, and making sure you know what's the nice-to-haves, kind of like car shopping. You might want to add the heated seats, you might not, and that's okay. Looking back, one thing I would say that we would have done differently is spent more time in that population identification period and the stratification to really be clear and more focused on the people we wanted to outreach. We kind of cast a wide net, and in hindsight, I think we should have narrowed it a little bit more and just done a little bit more in the clarity on what it was we wanted to know, our success measures. Know that, be more clear up front in the evaluation.
Great stuff. We covered a ton there. Incidentally, folks, we have a Q&A module if you have follow-up questions for Tim or Jamie, and we'll try to respond to those with written responses if we can, and if I have time, I may be able to interject a few. But we do have a tight schedule, full disclosure. But the Q&A module is right there if you hover over the bottom of your screen. So Jamie, what you're describing, I think exposes something uncomfortable. We often measure activity and assumes it sort of equals influence. So outreach volume, completed visits, filled prescriptions, but signals can create a false sense of control. And so, Omar, I would love to bring you in. Where do you think where do plans think they have control? let's say over chronic disease management, but maybe they don't?
No, it's a great question. And first of all, I love how you come to the psychiatrist when things get uncomfortable. So happy to fill that role here. But I will say this: I love that you said sense of control when you were talking about signals, because that's exactly right. It stems from a cognitive bias and the idea that signals can be mistaken for outcomes. And looking at one thing and it being mistaken for another. And I'll give you in the audience like 4 or 5 concrete examples quickly on those. And the first actually goes back to what Jamie was saying when they tried cold calling from the clinical registry and found that it wasn't working. And that's that a common mistake is to confuse outreach volume for influence, because volume is really an operational metric. It's not a behavioral metric. You can touch someone 10 times with outreach and not change the behavior. And I think we've seen that. So plans can measure like attempt rates there, but it's very difficult unless you're going all the way down to the granular level that Tim was talking about, to measure decision point impact. So outreach then without context then just becomes noise. So that's the first. The second would be mistaking a completion of a visit with behavior change. And Eric, you talked about this at the beginning, which is, if you look at a completed visit, that's really just a documentation of intent. It's not evidence of real execution. And the clinical plans that we, doctors make decay very rapidly. You talked about the PT example, very, very rapidly without reinforcement inside of the daily routines. And we know that where behavior fails is really inside the kitchen and in the grocery store, and the decision to watch that next episode of let autoplay on the next episode of your favorite show, and not in the exam room, So that's the second kind of mistake. The third one I'll mention is mistaking education for engagement. Tim alluded to this too when he talked about educating, but it not sinking in. So what does it really mean for it to sink in? And what I'll say from a behavioral science perspective is that information does not compete very well against habits, against stress, against environment. I already know that I shouldn't eat the pie, but guess what happens? I eat the pie. And so it's impossible to be against education. Of course, we should educate. But if we're deploying resources against education and not about kind of addressing that activation energy and removing those barriers, engagement is really about these repeated micro actions. It's not so much about content exposure. We can also see many others like medication fill rates that are confused for adherence. Fill confirms the transaction, but did I actually ingest the medicine? Did I inject the GLP, or is it collecting in my drawer? Is it a $5,000 failed experiment that never entered my body with autofills every month? And so without that daily signal, we basically discover months too late that there's been non-adherence. So, and the same thing's true with quality. So what I would say is, if we want to move beyond this, and I loved your expression, sense of control, to actual influence on behaviors, the first step is we've got to be honest with ourselves about what we're measuring and what it actually means. It's a great question.
Thanks. That was great, Omar. Appreciate it. And I guess, so many of the signals that we rely on, create that false sense of control. So I suppose the next question becomes, what does real operational control actually look like inside a health plan? So Deborah, Healthfirst has been using predictive analytics around admissions and discharges to intervene earlier. How are you translating these signals into action?
So Healthfirst has realized that they have a lot of work to do between the visits that the patients make if they're going to advance the healthcare. And I love the term health span rather than lifespan. One of the areas that we're spending a lot of work on is using what we have on our plate already. So we already have admission, discharge, and transfer notices. Over 80% of our healthcare transactions are reported in our HIE, our Health Information Exchange here at Healthfirst. We are now curating those incoming messages to build on what Omar was saying, to decide what to do with them. Admission to the hospital, visits to the ER, transfers to a SNF, transfers to home health care. And we've enabled those signals to be placed in front of people in our team to take action. whether it's curated care management for a baby that needs to be helped for transferring out of the NICU into a placement, which I just helped with this morning with one of my nurse leaders, as well as linking it to other data. The data that we do link it to is our analytics, our predictive analytics that we use on our existing databases when it comes to claim transaction, lab results, and pharmaceutical transactions. So we've married all that data together to say we have many populations. Our members speak over 57 languages. We have about 8 populations that we
I'm sorry,
target.
you said 57 languages?
57 languages. So we've curated actions for 8 big groups. And then we started doing smaller curation. What does it take to nudge a patient or a caregiver, a family member along between the visits? Did they pick up their meds? Did they make the scheduled appointment with the next provider that they need to see? Do they need anything else? And you use that term nudge, Eric, and I use it because I am a nudge on this kind of stuff, because my feeling is you can move so much if you just use the tools that you have at hand and think with your executive thinking skills, how to use those tools in a way that's going to be effective and not wasteful in the amount of resources. So we have care managers will come in to work in the morning. That predictive modeling would have told them what they needed to do for that day with their groups of patients that they were assigned for specific actions. And I'll point out that Healthfirst did obtain 4.5 stars for this year. We're the highest star rated plan in the Northeast that's not a group model or staff model managed care organization. And we have 2.2 million members and over 60,000 practitioner tax numbers that we deal with in the greater New York City area. And so I've been really pleased with our technology marrying with our clinical people, our subject matter experts on both sides, to use those spaces in between visits, Eric, to come up with what's the next thing we can help that person achieve.
I love it. The nudge strategy got you to 4.5 stars. That's fantastic. By the way, I do use that term, but I tend to get nudged by the women in my family. I don't do the nudging, just for the record. I think what you've described, I like what you described, Deborah, because it brings like the threads that we've discussed so far all together. I mean, right? We've talked about the visibility, we've talked about the engagement, we've talked about the illusion of control, and the challenge now for the plans is operationalizing all of that in a way that actually changes outcomes between encounters. And it seems like you're doing that really well. I want to, it's a good segue because Dario recently developed an ebook in part in preparation for this episode. It's called Care Without Proximity, a playbook for health plans. Our team did help with the editing, so it's good. It's a blueprint for what we've been discussing today. And the core idea is, most health organizations are designed to answer the question, can the member get care? But outcomes are determined by the question, what happens after they get it, right? And so back to that, my trainer example, the appointment or the training session creates that direction, but the progress is going to happen in between the sessions. So this playbook, I would say, it outlines how leading plans are shifting from episodic outreach to continuance guidance by combining the behavioral signals and everything else. So if you want that content piece, we'll send it your way. I'll personally send it to you, so you have it as a PDF, and you could just click on that poll there if you're watching us live, and you could request it directly through us through email if you're listening to the podcast. All right. So as we continue this conversation, I think what we want to talk about now, are we funding access or are we designing for sustained outcomes? And so let's make this concrete. Omar, can you walk us through an example of an organization that believed its cost problem was access to care, but ultimately discovered that the issue was what was happening between the visits?
Great question. So, we've admitted we have a problem, right? And so that's the first step. And we have a sense of what we need to do about it. But what happens when we actually find that there's a gap between what we thought the problem was and what the problem was, and then implement a solution around what the problem actually was and what are the outcomes. And there are many examples, but I'll give you one. This was a large self-insured New York financial institution, and they were dealing with, as many are, I'm sure in the audience know, rising medical and RX spend that was driven by obesity, diabetes, and hypertension. Just looking at the NDC codes, just looking at the data itself, it was clear that was driving it. But they assumed it was an access issue. Nevertheless, they were open to trying something different. And the reality was that it was less about access and more about what was happening between the visits. And so they had access to, they operated based on what they could observe. And what they could observe were episodic claims and lab data that showed them snapshots, but there wasn't a way for them to see daily behavior. And so one way of putting that is that they had some retrospective clarity, but limited forward visibility and almost no real-time or inter-episode data. And that's, in some ways, that's operating in the blind. No visibility, for example, into the person's actual weight or their blood pressure on a daily basis, or what their glucose trends look like in real time, or how they're eating, or all of that, to activity. And so what they're essentially doing was underwriting this kind of multimorbidity without really having the tools to necessarily actively manage it. And to deepen the insight into the problem, they had a variety of vendors that created this massive data exhaust for them, but no coherence of signal. So, and multimorbidity really thrives, as we've talked about, in these myriad decisions that exist between the visits. You talked about 167 hours, but people don't see their doctor weekly. This is many months of not being able to see what's going on. So the solution was, implementing Dario. They shifted from layering these hodgepodge solutions to implementing an integrated cardiometabolic behavioral program. That meant that they had visibility into more continuous weight, blood pressure, glucose engagement data. That gave them visibility into estimated A1C instead of waiting months for labs. And members had coaching that was embedded into their daily routines, things like meals and when stress spiked, and what we call sedentary drift, which is this natural tendency to move towards not doing as much as you did when you were highly motivated. And so by integrating behavioral science into this, we were able to reduce that friction, influence members' real-time decisions, give the plan back visibility as to what's happening between these visits, and manage this between visit interval. So what was the result? That was your question. About half, nearly 50% of members with a BMI of greater than 30 lost more than 5% of their body weight. And actually the average was 7.7% in that group. Stage 2 hypertension, which is the more severe high blood pressure, their systolic blood pressures declined by over 10 millimeters of mercury. For your audience, that's a very clinically significant reduction. That's a reduction that impacts cardiac endpoints. Almost 2/3 of members, 64%, with an estimated A1C of greater than 8, improved by more than 1 point. And then if you just look at the savings, the medical savings were $119 PEMPM. The pharmacy savings were $120 PEMPM. When you had the highest risk trimorbid members, that generated order of magnitude higher savings. And really the plan was shifting from passively measuring risk to actively shaping these kinds of longitudinal outcomes. So if the first step, as we've talked about, is recognizing the problem, then the next is implementing solutions which people enjoy and like to use. I would encourage your audience to look for consumerized solutions that have real-time influence on what people actually do in the grocery store, at home, et cetera. And with partners that are taking accountability for their outcomes, that are putting their outcomes at risk. Yeah, great question.
Yeah, I love it. And those are impressive outcomes for sure. Folks, before we move into the next discussion topic, just want to tell you about a couple of upcoming episodes. And by the way, we're going to send you a feedback form on how we did today and ask for ideas on how to make the show better. That will happen in about 15 minutes. We'll send it to you by email. We'll also put the link in the chat. But to that end, one of the best suggestions we got was, hey, help us register for upcoming shows so we don't have to always do it. So we have two upcoming shows that we're going to be doing live, one on March 26th, the next on April 9th. They're both at 12 p.m. as they always are on the East Coast. We're covering AI and specialty value-based care. Get this, folks, moving from episodic care to longitudinal outcomes. So you're going to get a different perspective with some value-based care and AI included in it. We already have Chief Medical Officer at Essence Healthcare, a head of value-based operations at Humana coming to the show. We'll have a few more guests we'll announce. And then we'll have one around MA strategy and what actually drives long-term viability. So a couple of really cool episodes. And in between those, we're dropping episodes that I've recorded with leadership at Sutter Health, recently just the CEO at Sidecar Health, which is a health plan out of Ohio, but it's a national plan. So those are episodes that drop in the podcast in between our live ones. Encourage you to check them out because there's lots of good ideas there. All right. So what we're hearing is, again, it's not so much about outreach, but it's redesigning daily life. And redesigning sounds, I don't know, I'll call it straightforward in theory, but in practice, it requires lots of decisions, financial, structural. So I'm going to bring back Tim Law, CMO at Highmark. Tim, can you share an example of a structural gap in care that maybe traditional models were falling short, and what changed when you decided to address it differently?
Yeah, for sure. So this relates back to when we first started covering digital therapeutics. So first, we pat ourselves on the back, thinking we're going to change the face of the industry and really get the care in the homes and between visits, and then realized that there was information overload, and the amount of technology that was coming out for us to evaluate wasn't even the tip of the iceberg for what people were getting hit with on social media for different apps for sleep, for fertility, for mental health issues, et cetera. And we had one specific I'll use is in the category of autism. Nationwide, the average time to get in to see a specialist to get your diagnosis was about 18 to 24 months. And it was similar to that here in our network. The problem is you can't get some of the state benefits and other type of treatments you need until you have the diagnosis. Many pediatricians won't do it on their own. They want a developmental pediatrician. So then you even add more time to that. You have psychiatric advils, et cetera. Out came an app that we looked at that said, hey, we can do this at home. And what it is the doctor, your normal PCP pediatrician, fills out a questionnaire about the patient, and the parents have a link at home. They take a video of the child in two different types of playing situations. One when they're playing with other human beings, children or adults, and another 90-second one where they're just playing on their own. And they also answer a questionnaire, and they send that back. We have specialists that review the videos, look over all the things. Anyway, they can get their diagnosis within less than a week. It comes to the patient, it comes to the doctor, and then they can get hooked up with whatever type of therapy they need, whether it be ABA, speech therapy, et cetera. The problem was, okay, now we have this app. Now we're going to solve this big 18 to 24 month gap. Now we needed buy-in from the company, from our own company, or from the industry in general. Like, are you going to pay for this? Who's going to pay for this? Is it going to be a buy and build, like where the providers can have to write a script for it, and then they get paid through the pharmacy benefit or through the medical benefit? And so then we started realizing, listen, when we make these benefits, they're not just it can't just be something that sits out there as a feature, a list of some features. It has to be part of a clinical statement. We have to be able to say that we as an industry, we as Highmark, we as a plan, I think this is so important that we're putting this extra tool in the toolbox of your physician to help get your child a diagnosis faster. And that's just one of the disease process that this happens in. But we started looking at across the spectrum, whether it be CHF, diabetes, et cetera. I mean, listen, we talk about the system not working well. Look at diabetes. You can't get your sugar checked regularly at home with a continuous glucose monitor if you have type 2 diabetes and you're not on insulin. So what do? You finger stick. Do you do that every day? Heck, if you're eating that piece of pie that looks so good that Omar talked about before, you're probably not sticking your finger every day either. And so we get a quick little vision of you once every 3 months or 6 months or whatever it ends up being. So we thought this had to be embedded into these covered benefits, and so that everyone could benefit from it. Not just a health plan, that we're getting better care more frequently, lowering the cost of care overall, so those healthcare dollars could be used for other things, but also the members getting better care by the provider. We thought, and our mantra has been, We want to be a conduit to appropriate care between a physician and their patient and not a roadblock. And for so long, the health plans have acted more of a roadblock than anything else. We're trying to remove those blockages so that it becomes part of a clinical statement from us. Say, we think this is important. You should think that it's important, and your doctor thinks it's important. And so we just move from that novelty to justification into a validation process. And it has really helped in multiple. Now, as we look at the population health part of it, it's helped in multiple different diagnoses other than autism spectrum disorder.
First of all, I love the fact that you're taking a bright spot in autism and you're going to move it into other areas. Any quantitative or just more descriptive qualitative overview of the results itself?
Yes. So we have our utilization in ABA therapy inside the autism order. Now, listen, ABA therapy has certainly been used for many different diagnoses, but we had a problem with children not getting in. Their first visit was somewhere in that 6 to 7 year old range because they weren't getting their diagnosis at around 3 or 4, where you can actually get the diagnosis set. And so instead, they were seeing something was different. They would start asking for the diagnosis around 4. They would get it somewhere around 6, 6.5, and not get into therapy till 7.
Yeah.
They've missed a huge window. And so we've seen our utilization slide from that 7+ age range, slide down closer into the 4-year-old age range across the board.
So earlier intervention, earlier engagement.
Exactly.
Love it. That's great. That's a great story, Tim. So redesign. I mean, it doesn't happen just with benefit design. It happens also with the relationships that get formed. And so, Deborah, how is Healthfirst structured or restructured parts of the organization around what I would call caregiver integration? And maybe explain to us what that means and what's been the business and clinical impact.
So we have over 330,000 people that are covered by Medicare in various products. And we began to study who is in the family of these members. This especially got us started during COVID, where we needed to understand how care was being provided, how people were getting the care they needed during very difficult times during the pandemic. In 2024, we put together a strategy that's wrapped around the caregiver being an integral part of the group of people that we have enrolled in our organization. What we found is approximately a third of the people have nobody, unfortunately, for them to help them with. A third of the people are taking care of themselves, but also have family behind them as a backup entity. And then a third of the people, almost all their health care would not be provided if it weren't for the daughters, the granddaughters, the nephews, the nieces, etc., because they need full coordination in the home as well as coordination by Healthfirst when it comes to accessing care services. So we had discovered that we didn't have a good understanding at all of who the caregivers were in the family. So we began to build our systems around identifying the caregivers, understanding the role that they had in the individual member's situation. So this is an integral part of our care manager process right now. We also rebuilt our digital capabilities to include caregivers as part of the outreach for our members. And this is a multi-phase plan. We have new things coming out in 25. We have more stuff planned for 26 and more for 27. We also made sure that we reorganized the issues around HIPAA, accessing information, powers of attorney, powers of financial decision-making, advanced directives, etc., because we were all over the mat. It's stuck in siloed type of arrangements throughout the organization. So we identified 21 different instruments. I was surprised when I realized how many there are that could be used by caregivers to help manage the lives of their loved ones. And we made sure that we had a coherent plan for how that information was gathered and held inside Healthfirst so we can use it. The relationship building is critically important. We found that many of our caregivers didn't know who Healthfirst was, didn't know what kinds of services that we could provide and help them with. So it's made us be much more successful at engaging elderly members or people with disabilities About a third of our people, by the way, are under 65 in our Medicare population. And it's also increased the satisfaction. So we actually survey caregivers for satisfaction, and we survey members for satisfaction related to these efforts. And we feel like we're only about 50% down the road of where we need to go. But I would, say that this is a critical part of the nudging factor. In this case, you're making sure that you're enabling the daughter-in-law, the daughter, the son to really be there as part of that team when we're not involved in the healthcare. Either the direct providers are not involved or the health plan is not involved.
Oh, good stuff. I love how this is kind of all just aligning. You guys are doing great. That was great. Folks, also need your feedback. Surveys going out in 5 minutes. We'll post it here right now. We'd love your feedback on how we shape those future episodes and cover different topics. It's how we cover and produce our agenda as well. So, our programming throughout the year. So, appreciate it. Thanks in advance. Jamie, what Deborah just described, it points to something like deeper, right? So you could build the infrastructure, you could redesign the workflows, but if members and families don't trust the system, the care doesn't happen or is likely not going to happen. So when you think about complex populations, what have you learned about the role of trust that doesn't show up maybe in your claims data, but ultimately determines whether care can happen to your members?
Yeah, that's a great question. And we've learned a lot recently. We in Colorado have been building something called the Colorado Systems of Care, or also known as COSOC, if you like acronyms. We love acronyms. And the simplest way to think about it is it's Colorado's version of a coordinated behavioral health system for kids. And we learned a lot from work they've done in Ohio at Ohio Rise. They've built a system similar. And really at the core, it's about making sure that young people get the help they need in their home, in their communities, instead of bouncing from agencies or ending up in hospitals or out-of-state placements. And it's really designed to keep kids in the least restrictive settings so that they can stay connected to their families, their schools, their communities, while getting the care that they need. But we know all of that coordination can be seamless. But at the core, like you're saying, trust is so foundational. If a family or member doesn't trust you, it makes it really hard. It's an uphill battle to get to those outcomes you want that I've described and what that system of care is designed to do. And 2 stories I want to share that are really, really terrific come from our partner, Savio. And they had a member, one of the first stories, they learned in the smallest moments, trust can be built, and it's simple acts of kindness. And they had gone to a client's house for the first time, and they arrived at the home. And as soon as they got inside, the member they were there to see wanted nothing to do with them, was yelling for them to get out, didn't want to do anything, right? Who are these people at my house? Get out. The team left. They came back the next day. They called and they'd asked, okay, we want to come back. What do you need to feel comfortable enough to let us come back? And the answer from the client was very specific. They said, bring me some chili cheese fries from this local restaurant in Colorado.
Makes sense.
Right? I mean, chili cheese fries. Who doesn't love chili cheese fries? And so the team returned the following afternoon with the chili cheese fries in hand, sat down with the whole family, and they ended up having a great session. Another story from the Savio team that they shared with us was they had arrived at a client's house for the first visit, and they got there and mom looked exhausted. I know all the moms can relate, right? We have days where you're like, how am I even functioning? And she'd just come home from work, unloading the groceries, trying to cook dinner. And she said, I don't have the energy to meet with you all. And instead of rescheduling, the team could have said, okay, we'll come back. We'll reschedule. They actually stepped in to help this mom. They unloaded her groceries, helped her cook her dinner, all while having a working session while they're doing all of these things. And by the end of the evening, the mom was so grateful to this team not just for their support, but for making her night a little bit easier. And since that day, that family hasn't missed a single session. And those really speak to the volumes of those simple acts of just humanness, human kindness, and the willingness to meet families where they are. So sometimes it might be the chili cheese fries is what's going to connect you. Other times it's just that helping hand in the kitchen when you're just having a really rough day. And I think it highlights some important things. If you zoom out even further, that trust is that foundational skill that helps enable things clinically, that the real work it can't happen until you have that trust. You have to have that before people will start to make the changes. And engagement requires dignity. So people participate, your members do, if they feel seen, if they feel respected, and if they're treated as experts of their own lives. And something that I can't remember who touched on it, but those between visit care, that relational continuity, it's really those small, tiny touch points in between that build that momentum that keep the families moving forward. That's so critical.
Oh, great stories. Those are great. I love that. Quick sidebar, 'cause we're going to move to like sort of sustainability now in the last segment, which I've been looking forward to. Folks, one of the things we started doing a couple of shows ago, I wish I could say we got this from the feedback forum, but it was sort of an idea I put together, was to improve all of you attending live. So I'm not talking to everyone listening on the podcast, right? I'm sorry. For you attending live, we've tried to put highlights as we go on throughout the show into the chat, kind of like live tweeting back in the day. Would love your feedback on if this is helping the experience or not, because my production team, which we've trained on doing this, and they're doing it so well right now, it's extra work, and I've asked them to do it. So I'm hoping it's improving the experience, but if it's not, I'd love your feedback on that. You could chat with me, fill it out in the survey. Always try to make this experience more valuable for you. All right, so I'm going to bring back in Dr. Manaswala. So Omar, we've talked about redesign, relationships, and trust, but at the end of the day, the leaders, many of the folks listening right now, they're accountable for outcomes.
Absolutely.
So what happens when a health plan moves from measuring what occurs between visits to actually to actively managing it?
Yeah, I think we're at the right spot to talk about this, with Jamie having talked about the importance of trust, kindness, and dignity, which actually gives us access to those moments in between care. Now we influence it, and what happens, and how do we get to sustainability? So when you're managing daily behavior, that's more than just observing the risk. You're influencing what's happening there. And at Dario, we call that compressing the clinical latency, the time it takes for the clinical decisions to reach outcomes, and that increases the clinical leverage of the intervention. So just as an example, there was an East Coast regional MA plan that was wanting to manage its diabetes population better. It already had vendor in place with specialty care, in fact. But they weren't really getting the visibility between the 6-month lab cycles. The trend was headed in the wrong direction. And the challenge that they faced was their assumption that older adults were lower tech and wouldn't be able to engage. And what they were able to do with implementing Dario is to see that the estimated A1C, the measurement of glucose, the real-time data, gave them the ability to have directional control rather than some kind of hindsight retrospective reassurance or observation of the problem getting worse. So what they saw with implementation was not just a 1-point drop in A1C in 3 months, but they found that sustained over 18 months. So they had durable outcomes. We looked deeper at the why. And there were many reasons, many engagement levers, things that they were clicking on in the app, things that they were using, measurements that they were doing by persona. But we also found that coaching was correlated with measurable glucose improvement. And our coaching is really focused around the idea that what matters to people is generally more important than what's the matter with people. So people will engage in what's relevant in their lives. So this longitudinal support prevented the kind of silent drift into decompensation. And so we saw, again, significant savings on a PMPM basis. on par with what we saw with the other earlier example I gave of the financial institution. And what you really had was a plan that was shifting from measuring risk pools to actively reshaping those pools. And so it comes down to I guess I would call it a strategic reframing, where between visit management turns chronic disease from this kind of actuarial inevitability into some kind of trajectory that you can modify. And the continuous signal that you're getting through this partnership creates earlier intervention points and therefore earlier inflection points in trend. And the financial sustainability, which is your question, that emerges from this really comes not just from reducing these isolated events, but actually altering the slope of utilization. And that's what this plan saw, one of our partners. Yeah.
Oh, that's gold. I love that. So I just came back from a big conference, came back from Vive, had so many valuable networking discussions. Some of them were impromptu. And it strikes me as we're talking about this topic and you're hearing Omar talk about some of the things he has seen firsthand, and obviously an expert in behavioral science, being a psychiatrist. If you want to just network, I'm not even talking about getting a Dario pitch, but if you just want to network with Omar and the Dario team about what they're seeing and what can be done, leveraging technology, behavioral science, and the human touch to bridge these gaps between appointments. If you want like a networking call, I'm happy to orchestrate that. Me and my team would. Actually, I'll do it. So if you want to chat with the Dario team and Omar about this, we'll put up a poll here and I'll set that up. I know it was a little bit unplanned, Omar, but I was just listening to this.
Happy to do it. Love it. Love the idea of connecting.
We got to get folks. Yeah. All right. I'm just loving this conversation. Right. So what Omar just described is certainly describes the impact. It's clear. But the reality is not every member, right, needs the same exact support. So Jamie, let's go back. Some people need their groceries unloaded, right, Jamie? Now, but when you're thinking about supporting members between the encounters, how do you decide like what should happen digitally, what should happen in person, and maybe what should happen within the community at a CBO?
Yeah, that's a great question. And one area I want to talk about is just our investment at Colorado Access, specifically in strengthening and diversifying our doula workforce. And we did this in the last few years with a particular focus amongst Black, Indigenous, and other doulas of color. And this really stemmed from the documented disparities that we knew existed in the maternal and infant health outcomes for birthing people of color. We were seeing it in our membership. We had this gap, and we knew in Colorado that we didn't have enough culturally responsive doulas, and there wasn't great infrastructure in place to help the doulas stay in the field, even though we know that research shows that doulas, the care can be linked to fewer negative birth outcomes. So in 2021, we launched a partnership with Mama Bird Doula Services, and we did that to expand the BIPOC doula workforce and increase the access for our members to culturally responsive support for our members. And in the years that followed, we added another partner, Elephant Circle, and they're an organization who focuses on birth justice and systems change to support doula training and workforce development. And through that work, we were able to help train more than 100 doulas, including immigrant and refugee doulas, to serve the families across the regions that we serve in Colorado. And in 2023, Colorado finally approved a Medicaid doula benefit. It was a really exciting time in Colorado. And that legislation allowed independent doulas in the healthcare setting, and doulas in practicing in group settings to be reimbursed through Healthfirst Colorado. And since we had already been investing in this space, we had a stronger workforce developed, and that really helped prepare us when the benefit became available statewide. And as that new provider type became available, we participated. It was key to partner with our state partners at the Department of Healthcare Policy and Finance. We were on different boards like the Doula Advisory Committee, where we really helped in those spaces identify and troubleshoot the barriers that the doulas were facing during the enrollment and credentialing. So you need to get them into your network, and it's not always easy. And so our role was to be a thought partner and an advocate for the doulas navigating the new system, as well as for the members for trying to access a brand new benefit. That's hard. And so we built on the longstanding relationships we had with both Mama Bird and Elephant Circle to enroll them into the Healthfirst Colorado. And by June 30th, 2024, we had 20 doulas onboarded and enrolled with Colorado Access. And today, happy to report we have 38 doulas with 7 who are in process. And we make sure that our teams, my team, has access to that list of doulas as well as any other member-facing team so that they can get our members connected to this great service that's available to them. And so when we think about big picture, right, that you were asking at the beginning there, Eric, is that the between visit care doesn't always necessarily mean it has to be digital. And sometimes the most important intervention is just finding culturally aligned human support, which we did with the doulas. And to help decrease those disparities, the equity requires the infrastructures, not just innovation. And the right solution depends on who the member is, not what the tool can do. So that's what we found with our doula work, that sometimes it's a person that you need and the infrastructure.
Nice. I'm going to jump. We have 2 more strategy questions I want to end with. I know we're getting tight of time. That was awesome, Jamie. So at some point, like, this stops from being about individual programs and it becomes a leadership and strategy question. So Deborah, STARS performance often guides kind of gets sort of treated as the reporting outcome, right? And then you alluded to your STARS increases. Like, what does it look like when STARS becomes part of your company strategy?
So at Healthfirst, in 2013, our chairperson and president, Pat Wong, made it quite clear that STARS was a central part of our organization. By 2015, every executive had been assigned a set of stars or at least 1 star. And I'm talking at the VP, senior VP, and EVP level. And we analyzed each of the STARS measures. We looked at what kind of technology was needed to support them, as well as what kind of business practices were needed to support them, and built governance around each of the stars. I'm in charge, for example, of the appeals and grievances and the CTMs for the organization. CTMs are the complaints that get reported to Medicare. We moved those star measures from 3 to 5 over a 5-year period of time. And moving stars is hard. Only a small subsection of organizations get a star measure to 5 stars. And we also had overarching governance capability that included all the executives of the organization. We have governance meetings all the time on specific star measures. We assign work, and we do multi-stage planning over a 2 or 3 year period because you have to keep pedaling fast to even stay at a 5-star level for each measure.
Sure.
And I would commend the integration of this responsibility into the troops that you have at the director, AVP, and VP level. And it is a significant part of the compensation for incentives for all those individuals. And we also celebrate the results of STARS, which do celebrate what we're doing for our members to help them be more healthy. So we make sure that every person in the organization understands, what does it mean to have no complaints? What does it mean to have well-handled appeals? What does it mean to have medication adherence? And going back to what I said before, most of these STARS measures require us to have between 5 and 8 different sub-strategies and tactics because of the size of our organization and the diversity of our membership, as well as the diversity of the providers, the doctors, the hospitals that provide the care. So it is also a great learning experience from my point of view, teaching people how to really unpack, analyze, and decide what to do on a concurrent basis, as well as link that to your overall strategy for the organization. And I've learned a lot being a leader by having this structure, and my accountability is to be on my plate working with my fellow peer executives at Healthfirst.
Good stuff. That was great. I can't. Yeah, we're just about at the hour. That was great. So yeah, I'm just not going to be able to get to the last question, which is fine. We'll have to do this again, folks. If we want to continue, this was just such a great discussion. Sometimes we launch these private two-way discussions following these shows with leaders just to continue the dialogue and dive in more. And this is a topic that I think we all want to talk more about it soon. We're thinking about doing something maybe in March. If you want to join us in a private event, let us know. We'll put up a poll here as we close out here. But yeah, the leaders you heard today, just great job. Thanks for all the work you did in preparing for this and for all the insights. I love that we're not redesigning visits, but we're redesigning what happens between them. And that's where obviously we get these sustained outcomes. I think there were a lot of bright spots you could use at your organization. Thank you all who are listening for spending the time with us. We do not take it for granted. A shout out to our producer today, Wakanda Luwangapai. She was great. And for bringing all of these great guests together. She deserves all the props. We produce this podcast and webinar for all of you. This is your Bright Spots in Healthcare podcast, folks. Take care, everyone. Have a great rest of your day.